Welcome everyone to our UMTRC webinar for the Upper Midwest Telehealth Resource Center. My name is Becky Sanders and I'm the Program Director of the Upper Midwest Telehealth Resource Center. We cover the 4 states of Illinois, Indiana, Michigan, and Ohio. We are recording today's webinar and we will have the slides and the recording tagged on our website, and the recording will also be housed on our YouTube page. Everyone today is in listen-only mode. We will give you the opportunity to ask questions throughout. We encourage you to use the Q&A function to ask questions and only use the chat function if you have technical issues. We will hold all questions until the end unless there's a very specific question about a certain slide, and then I will interrupt our speakers to address that. Without further ado, I would like to introduce our speakers for today, Marie Lee and Courtney Stevens from Henry Ford Health System in Detroit, Michigan. Ladies, go ahead and take it away.
Great. Thank you so much, and thanks for the opportunity to present today. Really excited to talk a little bit about sort of the next level in virtual care. So my name is Marie Lee. I am a virtual care consultant with our virtual care team here at Henry Ford. And we're looking today to talk a little bit about the broader spectrum of care that we can deliver, what's beyond audio and video, and how can devices that allow us to actually do a physical exam really broaden that spectrum of care. And we'll look at a couple of examples that are very specific in terms of care redesign. So not only for in-clinic type opportunities or in-office type opportunities, but also direct to consumer opportunities for our patients who are at home or wherever they happen to be. And then look at ways that we can use this technology, and I think this is where we gain a lot of efficiency, is to really be able to leverage scarce resources of providers so that they can see a wider range of people across a larger geography, and again, facilitate growth and access to collaborative care. So bringing people into the fold, getting that more comprehensive physical exam, but not having to physically bring them to an office location. Henry Ford Health System is located primarily in southeastern Michigan, but also in lower central Michigan. So we've got our concentration again in the Tri-County area, but then also in the Jackson area. And so again, these are our statistics. We also have a health insurance arm underneath our Henry Ford Health System umbrella Health Alliance plan. We are an Epic EMR shop. So for those of you who are interested in what EMR we're using, we're on Epic May 2020. That's the version, and we've been live with Epic since 2012. Our virtual care mission statement. This is important as this drives what we're doing and how we evolve as a department and as we're working with our health system to go to that next level and really see what else we can do to reach patients and in a more comprehensive way at a distance. Our mission statement is, again, is evolving innovative care delivery to enhance health and wellness through accessible technology that drives connection and collaboration where, when, and how it's needed most. And our key was really that virtual care is not technology plus a doctor or technology plus a provider. We know that those two things alone are not enough for quality care. It's really about all of the other things around that and trying to give that quality care and translate what would be in-person care and quality in-person care to a virtual environment. And at times, we haven't been able to do quality care at a distance because we've been lacking a few of those elements. Our virtual care mission really is about the right patient, the right time, the right intervention with the right provider in the right place. And what enhanced video visits allows us to do is really expand that right place and that right intervention. Traditionally, audio and video allowed the provider to get a patient history, assess the level of patient distress. They could hear how they're talking. They could see how they looked on video. Obviously, it lends itself, audio video lends itself very well to behavioral health situations. We can do a lot with a psychiatric evaluation. We can do a lot of counseling sessions. And then from a camera standpoint, depending on the type of camera that the patient has, we can do a skin exam. We can see rashes and things like that. But again, depending on the patient equipment, it may or may not be super high quality. With a video enhanced examination, when we have devices that allow us to do the next level, we can do all the things that we can do with just video and audio, but then we get a very high definition camera. We have an otoscope that allows us to see in the ear, nose, and throat. We can listen to the heart and lungs. We can possibly even get Bluetooth enabled devices that allow us to do pulse ox and weight and blood pressure. So there's more things that we can do, basically almost everything except for the physician physically putting hands on the patient. And even at that, a lot of times the physician can walk the patient through really basic hands-on processes, and or if the patient has a caregiver with them, they can walk that caregiver through what they want to try or where they would want to find out something more detailed on a patient by touching them. We're going to talk about TitoCare. This is the device-enabled equipment that we're using as a health system, and this screen shows the patient view. So the patient would have this equipment in their hands. The white device with the screen that you see is really about the size of a softball, so it fits in the palm of your hand, and it has different attachments that allow the provider to direct specific exams. From the patient end, additionally, besides the device, they would need some sort of mobile device, whether it's a smartphone or a tablet, to be able to walk through the exam. So they would see the provider and hear the provider on that smart device, whether again, it's a phone or a tablet, but then they can also see not only on their smartphone what to do next on the physical exam, but they also see it on the screen of their device. So it's a very user-friendly platform, and it does give a lot of visual cues for our patients to walk through those exams. This is a listing of the exams that can be performed with the basic TitoCare set. So again, ears, nose, and throat, listen to the lungs, listen to the heart, get a heart rate, get a temperature, do a very high definition camera skin exam, and even listen to abdominal sounds. From the provider side, the providers are using a computer. So again, traditional computer monitor, they have to access this cloud-based platform through Google Chrome, just as this is, again, what the platform requires. And the nice thing for the providers is they have a good amount of real estate on their screens. Hopefully it's a big enough screen where they can see the audio and video from the patient, but then they can also direct that exam. So what the patient is seeing is also what the provider is seeing as far as the outline of the patient and where they should be placing the device, depending on the exam that was asked for. So we'll take a look at a throat exam, and there's no audio for this video, but what I'd like to do is show, again, the animation that they have on the screen. And this is a video and then an actual video of what happens when the patient is doing a throat exam. They can see on the device, and they can also see on their phone. So if they're doing this themselves, it's kind of obviously difficult to see what the device is seeing because they're pointing it at their face. But on their smart device, they can also see the view that the provider is getting. So it helps them really get the best view. And again, sometimes it's helpful to have a caregiver assisting, but it really is meant to be user-friendly as possible so that the patient could do this exam themselves. The patient is listening to the provider. If the provider needs them to tilt it up, tilt it down, whatever, they should be able to see that on their device and get that very clear picture. Oops, let's go to the next slide. This one also shows, I believe, the ear exam. And again, there's no audio on this, but she'll walk through that exam and what it looks like. It's really showing, oh, in this case, they're switching to a heart exam. So it's saying what device they should connect. So in this case, it is the stethoscope. The avatar of the body shows where she should place that spot so that the provider can get the best auditory cue and listen to those heart sounds. she has a t-shirt on, and what we've found is that it works really well through thin clothing. It works even better when it's placed directly against the skin. The provider is now switching to the otoscope. And again, it's just a quick snap change, and she is doing this herself. It's a little challenging to do the ear exam on yourself, but she's doing a pretty good job. And again, she can see it on her device, what the provider is seeing. And then the provider says, great. And then they can switch the device. Now they've switched to the throat exam. The provider at certain points can take short videos and or still pictures of those exams. And then at a later point, if they needed to review those, they could. At this point, we're not completely integrated with our electronic medical record system, but they could clip those images and put it into the patient record. As you see, the provider is actually documenting. So there is a documentation piece to TITO Care. This is their TITO Cloud. The exam is done over their, again, online platform that is accessible via the web. We're hoping that this will become much more integrated with our electronic medical record system, but at this time we're accessing it, or the providers are accessing it over the cloud. So that's the overview of what TITO Care does. Before we move on, Courtney, did I miss anything in any of these online exams, or did we need to review anything else that I might have missed?
Yeah, I just wanted to go back. Can you go back to the first video real quick, Marie, and just
Sure
let it
thing.
run while I'm talking for a second?
Absolutely.
So one of the things, and by the way, my name is Courtney Stevens. I'm the Director of Virtual Care here at Henry Ford. One of the things I wanted to point out about this video is this is intended for their exam and forward. So these ones are not in real time, but the patient is collecting these videos, collecting these clips, and then sending it into the provider. It's an asynchronous option. And so what's really nice about what you saw in that video again, and Marie, if you can get it to play just one more time while I'm talking too, because it's so short, you'll notice that there's a little green circle that appears. So here it's showing you a picture on the bottom of here's what we're trying to get to. And then when the patient actually hits it, it has some augmented intelligence in there that kind of indicates to the patient, yep, you've got it, hold it there. And so again, when you're doing an asynchronous exam with this, it needs to have some of that patient advising or patient directing, because it doesn't have the real-time component of the patient or the provider being able to direct the patient. Now, the second video that Marie showed, and you don't have to play the video, Marie, but just to show, for example, this is looking at that provider view. So she mentioned on a computer, you got to see the video on one side, you got to see the exam happening on the other side, and the provider is seeing kind of both of those at the same time so that they're able to direct the patient and have dialogue with the patient while they're directing them through the examinations like they would if that patient was in clinic. And so that patient on their smart device is seeing the provider's video and also seeing these directive images and avatars like Marie mentioned, so that it's helping with the provider's dialogue as well to direct them through their cadence of exams that they would like to do. So it's a very interactive platform. We found it very useful in a lot of different use cases, which I'm going to share with you in just a moment, but really gives that just like in-person experience for that patient and provider, even though they may be at distant locations. So
the last thing I would mention too, the avatar that you're seeing is based on what was entered as far as the patient. So the patient gets very basic information in TITO Care, name, a patient identifier, date of birth, but also gender. And so based on gender, that's what's driving that avatar, which is also helpful.
Yep. So moving into the next slide, we're actually going to talk about some of the use cases and opportunities that we have been using and are still planning to use this tool for moving forward. So there's three buckets that we're going to touch on. One is a direct to consumer. So this can be either that asynchronous mechanism or synchronous, and the patient directly being able to interact with that provider. There's also a high utilizer and chronic care use case that we're going to talk about. And then finally, we have some partnerships with employers that we've been using the device for to offer either an on-site clinic using this technology or more of that virtual clinic to some of employer partners that are looking for different and innovative healthcare opportunities for their employee base. So moving to the next slide, wanted to do a high-level overview. So Marie mentioned in her overview some of the interactions and interoperability that we've been working on with our electronic medical record. So if we look at the care setting or the clinical settings, and so this would be like those on-site employer clinics or what we refer to as a clinic-to-clinic scenario. So the patient is still at a clinical facility, be it a skilled nursing facility, a clinic, an emergency department, but they're connecting to a distant provider at another location. Within those scenarios, it's a Henry Ford Health System provider at a central site that is that distant provider that's offering the service. Typically, there is a telepresenter on site with the patient to help navigate them through using the technology for this technical connection. In most of our use cases, it's a nurse or a medical assistant, but in some, we are also using community health workers or community paramedics that can also be that telepresenter at elbow side with the patient. And so with their role, they conduct some pre-visit assessment, they take initial vitals, be it either using TITO or another mechanism, and they can also take some things that are not facilitated through or may be done manually, like blood pressure. And also they do a thorough sanitation of the equipment, pre and post use. So the device itself lends to alcohol wipes, as well as the otoscope has removable and disposable attachments to it. The tongue compressor has disposable pieces to it. So they kind of help make sure from an infection control perspective that the device is being fully sanitized before and after. From a scheduling perspective, we have specific visit types that we use within Epic to be able to schedule these. So although the connection to the video platform is not integrated with our Epic instance right now, we still use Epic for all of our scheduling and documentation. Then the connection piece at this stage in the game happens outside using the TITO platform, but we're investigating integrating that as well. On the direct-to-consumer side, so this would be the patient is self-navigating the device themselves. Again, it's a Henry Ford provider and at a central site is the distant provider. And the telepresenter is either the patient or a caregiver that they have on site with them. And still scheduling is happening through our electronic medical record, but we're looking to use our on-demand video visit service as the delivery mechanism for this. So the patient can either initiate it through our on-demand video visit workflow or a specific visit type that they would have scheduled for using the TITO device. And again, all documentation and billing are also done through our electronic medical record as well. Next slide. So here's the first use case that I'm going to share. We've partnered with our school-based health program. So Henry Ford has a relationship specifically with a lot of Detroit public schools, but also some other school districts as well, where they are able to service students in the Detroit public schools that lack pediatric services. This is often a population that has high ED utilization, and it can cause high absenteeism in the school as well, which can impact school funding, as well as learning and quality of education for these students. So Henry Ford, with their partnership, already has nurses situated within some of these schools. So we leveraged that existing infrastructure to have Henry Ford Medical Group nurses on site be that telepresenter for the student when they're connecting and have the need to connect with a pediatric nurse practitioner or physician at a central location. This gave an added level of support and resource to those nurses that are currently on site in those schools. Some of the challenges and some of the key steps in this process was the schools, and in the partnership with these existing nurses on site, made sure that they received parental consent forms at the beginning of the school year, so that at any time, if the student needed to be seen in the clinic and then connect using telemedicine to these providers, we had that consent form on file already. Once signed, it allowed us to have that continuity with that patient throughout their duration of that school year. Next slide. So here's some of the outcomes. There's a 10,000 new students in less than 6 months that the service was made available to. It increased access and utilization of those nurse clinics, and also gave the ability to open school-based clinics faster on a timeline due to less cost and construction by using technology to connect to these higher level providers and have a more comprehensive exam. So the service is offered in 14 schools in and outside of the city of Detroit. And even though in spring, some of those schools were closed and some of those schools have distant learning or hybrid programs during the pandemic at this time, those clinics are still accessible to those patients and students for their use when they are on site. And some of the schools have even used that mechanism as a community testing site as well to be able to have an additional connective opportunity to additional healthcare providers. Next use case. So the second use case that we'd like to share with you is our home visiting physician program. So again, Henry Ford had an established home visiting physician program where physicians would physically travel to patients' homes who had comorbidities and especially barriers to travel of getting to their visits to be able to help have continuity of care and connection with those patients. So by using this innovative device-enabled exam for this support system, we were able to have meet the more demand that they had, the more demand that they had, but the limited capacity of providers. We were better to have better utilization of those providers. And it also reduced their windshield time, which then helped increase those providers' utilization as well. So from these interventions, we partnered with community health workers to be the individuals that went into the homes with the TITO device to support the patients. And they would have multiple community health workers out in the field simultaneously so that the provider could go from community health worker 1 and have the complete visit and interaction. And while that community health worker was cleaning the device, packing up, and heading to the next location, the provider could be connecting to community health worker number 2 and be seeing another patient immediately after they finished that first visit. So again, it helps to improve the utilization of these physician resources. Some of the challenges that we came across during these use cases was the network and accessibility within the patient's home. So we utilized MiFi or a hotspot that they could bring into the patient's home to get a reliable and secure internet connection. But even with that, sometimes depending on the patient's home or the way that the building was situated, there still was some challenges with that internet connectivity. Also, the staff reliability. The community health workers are a great community-based organization, but making sure that we had reliable and continuous support through them, that they would be available and they would be trained in how to use the device so that we could continue to move forward with the project. And then finally, the logistics of technology, making sure that equipment maintenance included, making sure the devices were charged, that they were turned on so they could get the necessary software updates. So having that administrative support and background and organization helped to make sure that we had that stable and standard process moving forward. From an outcomes perspective, the providers are now able to see an increased number of patients. They still do their first visit in home, the physicians themselves, but once it's assessed that the patient would be open to and consents to having follow-ups using these visit types, they're able to engage those community health workers to have them connect and go into the patient's home for their future visits. And then also with the COVID impact, there was an increased demand for this service, and it limited those patients having to find ability to be able to get out of their home. And we also had to make sure we were protecting those community health workers going into those patients' homes as well. So there was some additional protocols put in place. Next use case. So our third use case is our employer clinics that I mentioned. So using this device within an employer's facility or location and having the ability to connect to a Henry Ford expert resource. So we have a video here to play for you of Dr. Peter Watson, the Vice President of our Care Management and Outcomes for Health Alliance Plan, So I'm going to let us play the video first, and then I'll walk through some of the needs and interventions.
So welcome to My Care at Work. This is a great new project that we have done in collaboration with the Henry Ford Health System and our Health Alliance plan. This is an opportunity to use technology to create an experience for patients that's real time in their place of work when they need it in order to meet their needs. The basic principle is to use a generic office space and convert it into a fairly low cost but high value model to deliver real-time medical care using a medical assistant, an electronic enabled exam device, and real-time on-demand virtual physician oversight.
Perfect. So I knew if I let Dr. Watson cover it, he would cover the keys. So you heard some of the key staples on the need to reduce time off work and give that employee that experience right on site. The intervention itself, using the device, we piloted this at our Health Alliance plan or insurance plan headquarters. It's staffed by a medical assistant, so there is that telepresenter on site to help support those employees. And we leverage our on-demand provider pool that is available to be able to be tapped into for these needs. And this way they can also follow and track within Epic as well. And so if you go to the next slide, we'll talk about some of the interventions and challenges that we had. So from a challenges perspective, identifying the clinic space to accommodate both in-person and virtual offerings, especially if you think about an office. We had to think about things like, is it carpeted? Is it private? Does it have a door? Are there windows? So we still had to find a space that was conducive to that clinical interaction. And then finding an engaged telepresenter. If you think about it, this telepresenter is basically running their own little mini clinic within this employer office. So they not only need to be engaged, but yet plugged in to their clinical partners, but they need to be able to also interact with those employees on that clinical floor to make sure that they are promoting the service and explaining to people what it is and that they can handle the services needed on site. And the other thing operationally to think about is what's the backup plan or the coverage plan. If that telepresenter takes time off or gets sick, who do we have that could step in and cover that clinic instead of having to shut that down if that telepresenter is not available? And then so we're looking for expansions to other employer groups, and employees may not already be a patient of Henry Ford's. And how do we accommodate from an insurance and a verification and setting them up as a patient within our platforms to be able to service them as well? So as an outcome, this specific clinic launched in June of 2019, and they had a strategic marketing plan, and that included that telepresenter getting out and talking to folks about the clinic that they had on site. There was 156 patients seen via the device-enabled exam from June 1st to March 13th. We have our data through March 13th because unfortunately that building did end up closing for COVID and many of those employees were sent home during the public health emergency. But we were able to gather some great data during that time, and the patient surveys indicated great success. So 91% indicated that the visit met or exceeded their needs. 82% were very likely to recommend, and 91% indicated that they would have missed work, likely or somewhat likely if they did not have this as an option. So although the clinic has been closed since March, there are plans to continue and then also expand to additional employers that are looking for this type of service. Next slide. So a fourth use case that we would like to share with you is what is called our Mobile Integrated Health Program. So the need is to reduce readmissions for our high-risk patients that are discharged from our general medical units to home and make sure that they are staying home and they're staying healthy. So the intervention that we put in place was offering the patients that are discharged from some specific units in our flagship hospital the opportunity to have a community paramedic come out to their home within 1 to 2 days of discharge with the device-enabled exam technology to do an assessment and connect to their discharging physician using the video and the technology to make sure that the patient is still doing well and stable once they're in their home. Similar to what we saw with our home visiting physician program, some of the challenges that we had was network and accessibility. So as we're going into that patient's home, we're dealing with different networks, different connectivity concerns. So again, we used a hotspot or a mobile MiFi device that those community paramedics could bring into the home with them to make sure that they had an accessible and secure network in their pocket. And then the coordination with the visit with the patient, making sure, because again, they just got discharged from the hospital, which means many of their lives and schedules were still in a little bit of disarray. So finding a time and date that worked well with them, but also where were they going? Many patients, when they're discharged, they're not necessarily discharged to home. They may be discharged to their sister's house because they need some additional help and support as they recover, or their parents or their children. So we also had to make sure that we were very closely aligning with that patient when we scheduled that visit, not only for a time and date that worked for them, but where were they going to be during their recovery so that we could send that community paramedic to the appropriate location. The outcomes, so the initial program launched in June of 2019 and then had a relaunch in April of 2020 as it reassessed the situation of the public health emergency. Since the relaunch, they've had 57 patients. And again, this was piloted with just 2 general medicine units in our hospital. And so they had 57 patients seen between May 31st and September 20th. But the preliminary data shows that the program has avoided over 45% of ED avoidance and readmission. So from a COVID perspective, we're looking to see this program expand to additional inpatient units and in additional service areas as well. Next slide. So the final use case that we're going to share with you today is our direct-to-consumer use case. So we have some operational pilots in planning. We are not currently live with any of these, but we are in that planning and implementation process. Our first pilot would be for Henry Ford Health System employees. We have 60 employees that have been identified through an internal survey, and we did some initial interviews conducted with those employees to identify their household size, the number of recent trips to either ED, walk-in, or urgent care, so that we could assess their potential utilization of the device. We're also looking at another pilot for our Medicaid population and targeting some of those high ED or high urgent care utilizers to see if this could be a useful tool within those households. And then finally, we have a program with our Henry Ford Cancer Institute to really target some of our head and neck cancer patients and oral chemotherapy patients to give their providers and care teams a more comprehensive exam while those patients are in their homes and on the road to recovery for their various ailments and diseases. So the pilots will help identify any process gaps before we launch on a broader patient population, and also our process flows as well. Everything from distribution to support. How are we really going to make sure once we put the device into the hands of the patient that we are there, awareness, education, orientation, and support to make sure that that patient has a successful interaction. And the clinical resources for these programs, the care will be offered initially using our on-demand 24/7 video visit provider pool, or select subset of providers, for example, for our Cancer Institute and some of the other more focused programs as well. Next slide. So to share with you some of the next steps, and we mentioned a few of these earlier, our EMR integration. So we currently do all of our scheduling and documentation within Epic, but the actual connectivity or integration to the video platform takes place outside of Epic. So we're looking to evolve that into a more fully integrated in the EMR where the video platform would actually launch directly from that Epic Navigator. And the provider would be required to access through that EMR portal. And then also, as Marie mentioned, we'd like to have some of the data or images, still images or videos that are being collected through that Tyto platform to potentially be also fed into Epic as well for those interactions. So if we're able to execute that, then the patient would, if they're doing the direct-to-consumer model, would access straight from our MyChart patient portal to be directed to the TITL platform, and our providers would be connecting through their Epic Navigator to then be driven to their provider web-based portal. But still, those front doors would be consistent using Epic and MyChart. Some additional use cases that we are investigating or discovery phase right now, we're looking at an ED Express Care program, skilled nursing facility alignment, either for geriatric care or for specialty consults, a new mom engagement program, a pediatric engagement program, telehealth and student or student athlete programs partnering with local schools and universities, and then also additional targeted patient populations like our immunocompromised patients as well. Next slide. So we'll wrap up our presentation and then open it up to questions here, but just in conclusion, our device-enabled exams allow us to offer a more comprehensive access to healthcare, meet our patients' expectation for online care, reducing the costs of time, travel, and convenience, either for our patients or for our providers and care team, reducing exposure by giving them access to these healthcare tools from the convenience of their home or location, and then radical convenience and achieving that market differentiation, connecting our customers where, when, and how, like it said in our virtual care mission, they want to be reached, and our all for you Henry Ford promise. And so our last slide is just our contact information, but from there, we'll open it up to any questions.
Thank you, ladies, so much. You guys always share such wonderful information. It's a pleasure to be able to see all the innovative things that you guys come up with. I'm curious, how many people, Courtney, are in your team now?
Yeah, so we have a team of 7. I'm the director myself. I have 4 virtual care consultants, which are those project managers that partner with the operational areas through discovery, kickoff, implementation, and go live phase. And then I have a virtual care analyst that helps with a lot of our data, as well as our equipment procurement and orders. And then we also have a virtual care instructional designer. So she manages all of our training curriculum, our training resources, both internal and external. And then she actually does our technical and website manner training as well. And she partners with the instructional designer team for our electronic medical record so that we can make sure that those pieces are plugged into any EMR training as well. But she's a great resource to make sure that we have good tip sheets, resources, both for our patients and our providers and care.
Mm-hmm. Very good, thank you. So now is also officially the time, I've got my own questions, but officially the time for folks listening today to put their questions in the Q&A so that we can answer them. Other questions for you. So you started out, Marie, showing the TITO and the video on that and how it really helps. I remember one of the first years that TITO was available in the United States, I talked at great length with one of the representatives at ATA that year, and they were showing me how it helps the patient. And I think what was it he said? Teaching them to teach themselves to get better results for the providers. What has been the providers' reaction in your health system about? Do they feel threatened that the patients are taking their own vitals?
Not really. I think that, I mean, I guess there might have been some hesitation in the past, and Courtney, certainly you can speak to it a little bit. I think one of the gifts of COVID certainly has been that our providers are embracing different ways of being able to see their patients, and especially with some of the specific use cases that we've covered, honestly, the providers are thrilled, especially cancer care. I think that providers are getting really excited about the opportunity to keep those those patients are in a clinic, in a physical clinic, so much that if they can reduce even a couple of the instances where they have to be exposed, but still be able to get what they need because they're so concerned about the health and well-being of their patients. So there was definitely a hesitancy to remove them from a clinical situation. And so this actually gave them a much better comfort level. And I think what has really helped in a lot of the times where we've been introducing this to providers, we've given them the opportunity to do hands-on, and their reaction is always, they're almost always surprised at how good the quality is, even over a cloud platform, even over, you know, a distant technology kind of thing. They're always really like, oh, well, this is actually really good. So I don't know that they're threatened per se. And I think that there's always an opportunity or always a need to have hands on the patient in the clinic, but in between time, this is a great opportunity.
Yeah, we've actually had a couple of our Chi champion physicians tell us that the sounds that they get through this is sometimes better than the stethoscope that they wear around their neck. And to get them to get their hands on it, try it, and give us that stamp of physician and clinical approval has really helped us kind of bring this to other groups as an option and opportunity. And what's also been interesting with the pandemic and everybody being kind of thrust more into the use of telehealth tools, be that even the purely audio video, is we've now had physicians ask us, well, can I just have the patient take their own blood pressure? You know, they're wearing their smartwatch, they've got a digital readout, you know, everything like that. So I think the providers themselves, and then along that line, the government, you know, regulations are starting to become a little bit more accepting of some of these personal vitals, Bluetooth, digital readouts that we have. And the beauty of a tool like the platform that we're using is it is a one-stop shop. So it is a one tool that will be able to do a plethora of things for the patient and provider during that interaction, instead of them having to collect various tools to be able to do it. So it's streamlined some of our processes with these use cases that we've applied with.
Yeah, very good, very good. As we're talking here, and I haven't seen any questions come in, I want to go ahead and put our post-event survey into the chat so that everyone can see that. And I do encourage you all to complete that. It's just a couple of real short questions. It'll just take a couple minutes to complete. But that helps us as a federally funded entity to send data back to HRSA, our funder. So we appreciate that feedback. So other questions that I had for you guys, and I just lost it. So what do the patients say? Well, I don't want to go there yet. How many, you guys already had a pretty good handhold on telehealth and a pretty developed telehealth program prior to COVID. So did you see a lot more providers jump on the bandwagon as part of COVID? What was that like, that transition within your healthcare institution?
A tsunami, I think is probably the best way to put it. So what was very helpful for us as an organization is exactly what you said, Becky. We had a good foundation. We had the tools in our tool belt, and our team ourselves, the virtual care team, had processes and standards around the EMR portions of these interactions, the documentation, the scheduling, even how we worked a project, you know, from discovery to idea to implementation. So what COVID did for us was it took, well, first of all, it took that process and it tested it. It most definitely, you know, put it to the extreme. But because we had that infrastructure there, because we had the processes there, we were able to pivot, and we were able to apply and expedite those to try to get many people who were on the fence before over the fence and using and enabled to be able to use the tool. Now, what it also did, because it tested the limits, is it stressed our technology, it stressed our platforms and everything in between. And so we're still working out some of the kinks, working out some of the bugs, and making enhancements based on the 100 visits a week to 10 to 11,000 visits a week, and that will put a spotlight on some of the sore spots or pain points that you didn't realize you had because of the low volume previously. So we were able to make some really quick changes and updates and enhancements, but it's an ever evolving process. And especially when you're dealing with patients in their own ecosystem and environment and on their own networks and using their own devices. And there might be 15 different varieties of what that looks like. So there's user error, there's things that are outside of your control that we're trying to put as many resources, information, and knowledge out there. And also a team of 7 can't do it for the entire system. We had to draw on a lot of our partners in the organization, as well as making sure that operations understood what they are accountable for within this process as well. So Marie's been a strong team member of mine that has been partnering with a lot of those operational areas, as well as those alignment areas like IT and network security. So she might have some additional things to add.
Yeah, again, what you can control, as much as you can control, when you've got a provider on site, you have control over the network, you have control over the equipment that they're using. The patient side is always going to be the wild card, but COVID really just, amplified the challenges because then a lot of providers were at home. The technology allowed providers who had to quarantine to continue to practice in some instances, which was wonderful. But the technology challenges just really became very, very, very loud as far as some of those issues. And so some of the changes we've been able to make have definitely decreased the challenges and the issues that we've had, even with providers at home. So it's definitely been a learning process, and that learning curve probably happened a lot faster with like 10 and 11,000 visits per week than it would have. And the urgency was not quite the same when it was 100 to 150 visits per week.
Yeah. One other factor I want to throw in there too that we dealt with both on the provider and the patient side was they weren't the only one trying to use technology in their home. So you also had kids distant learning, or kids who weren't distant learning at the time and maybe they were streaming videos or playing games or something like that. They had spouses at home trying to remote work. So it was for a while there, it was a strain for some of those factors as well. And so the organization put some minimum requirements out there. And I think at first people thought we were just being very strict, or we were just being even sometimes difficult. But then I think when they realized everything that was being put into that equation that Marie showed earlier to make a successful connection, it started to click with some folks. And that also led to some of our support and champions and adoption that, knew that we were really doing this for the good of the system, for the good of the providers, and the good of the patient.
Yeah, absolutely. We've had many questions about broadband barriers and how do you do that at home. And yeah, I think you guys did an awesome job with that. One of the other things that you guys are lucky in the state of Michigan that your Michigan Medicaid department was so forward thinking, because they were getting ready to release the patients could be at home anyway, right when COVID hit. So they've already now, I think it was end of June, the governor signed the bill. And so going forward, whatever happens with the public health emergency, Michigan Medicaid beneficiaries will continue to be able to stay at home.
Yes. Yeah.
Do you know off the top of your head what your payer mix looks like?
I do have that. If you actually, if we go to the next question, I think I do have that. Just give me a second.
Pause, and Courtney will be able to give you that information. She's got it almost literally at her fingertips.
And I just had this open too, and I just closed it.
Oh, that's all right.
Anything else I can field in the meantime, Becky?
I'm trying to think where my brain was going. Courtney preempted my question about the patients at home, so that was my next question.
Yeah. Well, and Becky, just to go off of that Medicaid conversation too, because we were part of that advocacy that was working with Michigan Medicaid to get that even before the pandemic hit. And so I do, employ anybody who is thinking about that or has opportunity to advocate with their states, especially now because of everything going on, that I think it's those Medicaid programs are starting to see the value. And so there's a great opportunity in that.
Yeah.
And I was just gonna say, and while I was talking, I was able to find it. So we are 43% 43% Medicare, 16% Medicaid HMO, Blue Cross was about 27%, 13% other commercial, and about 1% self-pay.
Okay, very good. Yeah, the advocacy is so important, and we've been doing a lot of work kind of behind the scenes at the limits, because we are federally funded. We can't lobby, but we try and do as much education as we can. And in the state of Ohio, they also now have, well, actually back in July of 2019, they put into effect laws that the Medicaid patients could be at home. And they've already signed into law some extension of some of the new waivers that came out during COVID for OTs and PTs and speech language pathology. So those are going to be carried forward past the public.
Yeah, I'll tell you, Becky, of the Medicare, and especially because Medicare is such a high % of our patient population, my biggest fear is when the pandemic ends and those patients can't be seen in their home, because they're not going to understand how they could and now they can't. So that home in the rural area waiver is a huge, pit in my stomach. I'm also concerned about the services and the provider expansion, because to your point, we have a lot of outpatient hospital-based service like rehab, speech therapy, nutrition services, that these beneficiaries have been leveraging those services via telehealth in their home. And so to take that away, I think is going to be a huge disservice to them. And then, finally, the audio only, being Michigan, we have, even within the city of Detroit, I've seen statistics that the city of Detroit is one of the worst connected cities in the country, because we have a lot of dark spots where people don't have access to broadband. And so telephone is sometimes the only mechanism of communication that they have. And so I understand that it may not be at the same rate of reimbursement, but to take that away, there is a digital divide that we will be stretching by taking that away as an option for some of those patients as well. So there, especially on that Medicare front, there's some of those areas that I'm very concerned once there is an end.
Yeah, absolutely. There's been a lot of effort recently, and I think it was just last Friday, the newest program from the Federal Communications Commission, the USAC's Connected Care pilot program, opened. So hopefully we'll see a lot of money flowing there for institutions to do more forward-thinking purchases and giving patients connected care devices and ensuring patient broadband in their homes.
Yeah, we've been looking at that FCC Connected Care grant, and what we found interesting in that is it was not for the telehealth platform, technology, or resources. It's specifically for that broadband, that connectivity. The concern I have, and I hope that we're able to find some footing in it, is it's only for a certain duration of time. So if you set up partnerships to get that broadband out there and the grant covers, let's say, 3 years, are we going to be able to maintain that beyond those 3 years? So I love seeing the innovation. I love seeing the funds being put in the right place to make this happen, but it can't be a pandemic response. It needs to be a standard care delivery process and foundation put in place that will stick.
Yep, absolutely. So last question, because we're almost out of time. And I apologize if you address this, but well, I guess you are. With the Tidal Care equipment, you're giving that to the patients and they're keeping it in their homes. What was the overall strategy as far as giving patients devices to have at home?
Yeah, so the first couple of use cases that we covered were more of what, there was a telepresenter on site, or the community paramedic or the community health worker was actually taking that device from home to home. So for those are in the hands of those telepresenters, the employer clinics, things like that. The last use case that we shared was the direct to consumer. So that's the pilots and the use cases where we're looking to actually put those in the hands of those patients. So we're still working through those pilots of patient identification, in getting the actual distribution process and everything in between, but we would actually be putting those in the hands of the patient, that they would be keeping those. There's maybe a couple of those pilots that they might be looking to kind of recollect them if it was, let's say, for a specific, like the oral chemo, if they're only on the oral chemo for a duration of time, but they're still working through some of the logistics of those programs. But in most of those direct-to-consumer programs, we're putting those directly into the hands of the patient.
And then who's covering the cost of that equipment?
So for the employee pilot, we're looking at having the patients purchase those. And so we're looking for some payroll deductions or flexible spending or health savings accounts that they could be leveraged to purchase those. And then for some of the other value-based programs like the Medicaid or others, we're looking at what our options are, or even partnership with Health Alliance Plan, that there might be opportunities that those be funded through some of those programs so that the patient isn't having to purchase the hardware itself, but yet they are still able to keep the device. So we're investigating a lot of different mechanisms. Some of them include the patient purchasing the device themselves, and some go down the route of what type of funding we might be able to find to help support the patient.
Yeah, I'm getting a lot of, well, as the TRC over our first dates, we get a lot of questions about who's paying for those patient devices. And I'm hearing a lot more that insurance companies, including Medicare, Medicaid, and commercial entities, are starting to think about purchasing those in conjunction with healthcare organizations, because they are seeing the better quality and outcomes when the patient stays at home and is able to be seen earlier in whatever, if they have a chronic care diagnosis or something like that.
Yeah. Really, one avoided ER visit, even one avoided urgent care visit, is going to pay for the device at $299. That's really a drop in the bucket in terms of cost. So it's definitely in the interest of the payers to look at putting those devices in especially those high utilizer or, again, chronic care type situations.
Absolutely. Well, and I just saw over the weekend announcements from CMS that they're starting to issue the penalties for readmission to a lot of hospitals throughout the country. So I think we'll see more and more patient devices at home.
Yep.
Yeah. All right. Well, thank you so much, ladies, for being with us. I really appreciate it and the opportunity to pick your brains a little bit. Everyone have a great rest of your day.
Thank you, Becky.
Thank you.
Thanks.